Good morning, everyone. Thank you for joining us. We're going to get started here in just a few minutes. All right, good morning, everyone. Thank you for joining us today. Welcome to ITUP's Policy Forum, California's Culture of Coverage, Achieving and Implementing Equitable Universal Healthcare. My name is Emily Casillo, and I am the Director of Programs for Insure the Uninsured Project. Before the session begins, I have some important housekeeping notes for you all. First off, this forum is being recorded and will be available on the ITUP Policy Forums webpage. Attendees can listen to this webinar through their computers or by dialing in using the number and passcode provided by the Zoom software. We also welcome you to utilize the closed captioning function. Just click on the CC button at the bottom of your screen to enable the live transcription feature. Today's forum will run approximately 2.5 hours, and we will have 3 main panels, each followed by a question and answer session. If you have questions during this forum, you don't have to wait until the end of each panel or presentation to submit. We encourage you to submit your questions using the question and answer panel, which you can also find at the bottom of your screen. When submitting a question, please indicate it if it's directed at a specific speaker. We will answer as many questions as we can throughout today's forum. Also located at the bottom of your screen is the chat panel. Please feel free to use this chat function to say hello or chat with other attendees. We will be posting relevant information and links throughout the forum in this place. And now I will hand it over to ITUP's Executive Director, Katie Hydorn, to get us started. Katie?
Good morning, everyone, and thank you so much for joining us. Thanks for the housekeeping, Emily. We're so delighted to have you join us this morning on a Wednesday morning for a discussion of culture of coverage. I'm very excited about the topic today and our lineup. And so I think we're just going to jump right in and get to the conversation. I think we're just as Insure the Uninsured Project with a 25-year history in this topic. This one is near and dear to our hearts. So I'll just do a little bit of background on ITUP, and then we'll move on to the conversation. So ITUP's mission and vision is to promote innovative and workable policy solutions that improve the health of all Californians. And our vision is that we believe all Californians should have a fair opportunity to live their healthiest lives. We seek a healthcare system that is universal, equitable, accessible, effective, and affordable. And we, as I said, are a 25-year-old health policy organization. Each year, as many of you know, we host our annual conference. We also host regional working groups. We run 10 of them across the state every year to connect with our local delivery systems, and that drives a lot of our policy work and also brings speakers to our attention that we like to invite to be on our statewide panels. We also started these policy forums, which allow us to go deeper into certain topic areas that are relevant in our policy space in Sacramento. And we really try to use those to bring together government, our state policy experts, as well as people doing the work locally. And you'll hear from each of those perspectives today. We also, of course, produce our ITUP fact sheets. So if you have questions about how to get into certain policy topics, just visit our website. We have a lot of information there, and we'll be sharing some of those throughout the day. And then we have 3 key policy focus areas: coverage and access, which is in keeping with our original purpose and mission, but we've also expanded into delivery system transformation and the future of health. So with that, I'm excited to unveil our coverage and access policy focus today. As I said, we have some wonderful speakers speaking from the government perspective, our policy perspective, the folks who have been leading the conversation around coverage expansion and health for all in the Capitol. And then we have the local community's perspective to specifically focus on strategies to outreach to and enroll the last populations that need to access coverage in California. So with that, I would like to start our government perspective panel. We have 3 speakers during this time, and after each of them, we're going to let them speak for about 10 minutes, and then we'll do some question and answer after each one of them. And then the next 2 panels will be more of a panel conversation format. So with that, Marco, thank you so much for being here this morning. I'd like to welcome Marco Meach. He's the Undersecretary at the California Health and Human Services Agency. Marco, please go ahead.
Well, Katie, thank you so much for having me today. And to all of you who are joining virtually, hello, and thanks for joining. Just appreciate the opportunity to be here today. And I'm just super stoked to be on the same panel as 2 incredible public servants who've done a tremendous amount of work in this space and have been tremendous leaders in many ways. So Kathy Sunderling McDonald, with the Executive Director of County Welfare Directors Association, and a true partner, and then obviously Assembly Member Dr. Joaquina Rambula, and I'm just really, really honored to just be on the same virtual panel with them. I also want to start by saying thank you to all of you, because we wouldn't be here as California hadn't been for so many who are part of this panel, and for organizations like ITUP who really have advocated for a really long time to continue to move towards the progress of universal coverage. And it is just so wonderful to be part of a state where we're really embracing this idea of universal coverage. And I just want to say thank you to all of you for the work that you do each and every day to ensure that Californians across the state in communities are accessing access to health insurance coverage. And our progress has been quite phenomenal. So I want to just acknowledge that progress. I mean, we as a state have experienced the largest drop in the uninsured rate. We started in 2013 prior to the Affordable Care Act at roughly 17% of our population being uninsured, to dropping to nearly 7% just in 2019. And based on some of the recent data coming out of the California Health Insurance Survey, looking at roughly maybe even dropping down to 6% in 2020, that is just tremendous. And I think that there's a lot more work to be done to ensure that those individuals who are eligible for some of our programs are actually enrolled, and then making sure that we go the extra mile and finish off and make sure that everyone in California has ultimately access to coverage. And I think fundamentally, you know, when I was in Washington working on the Affordable Care Act and its implementation, we really looked to California to learn from its experience. But then California took the entire toolbox of the ACA and really ran with it, both the expansion of the Medicaid program, as well as the implementation of our tremendous Cover California or exchange. We've been able to make some incredible progress in really bending the curve when it comes to the number of uninsured. And when we look today, just the number of individuals that are insured via our public programs, so that includes Medi-Cal, Medicare, and Covered California, we've made a really incredible dent. And when we look at the remaining individuals that are uninsured, there's individuals who are eligible for employer-sponsored coverage. There's those that are eligible for Medi-Cal. There are those that are eligible for Covered California, both with subsidies and without subsidies. And then we have a proportion of the population that is undocumented and not eligible for some of these. And so really looking at ways in which we lean in to ensure that the remaining population that is uninsured ultimately gets insured. And the state has had played a tremendous role in really moving the conversation and the dialogue in the space. As many of you know, under the Trump administration, the individual mandate went away, and we took swift action as part of the 2019 budget, along with our colleagues in the legislature, to institute a state mandate to stabilize the market. And we also, through that process, authorized close to $1.5 billion over 3 years in state-supported premium subsidies to provide additional financial assistance to low-income consumers. And this was really a first in the nation subsidy program that also expanded to middle income consumers who were not eligible for federal subsidies. And I think that has played a tremendous difference in furthering this notion of a culture of coverage, which we're really, really proud of. We built on that even more by leveraging our Medicaid program. And I'm so proud that we've been able to build on the success of the ACA by expanding Medicaid coverage to children, young adults, and older adults age 50 and over, regardless of immigration status. And that is kind of a big proportion of individuals who remain uninsured, and in leveraging our Medicaid program to further this work in this way is quite profound. And the most exciting piece for me is that under the governor's proposed budget for 2022-2023, we are also proposing full scope Medi-Cal for all income eligible Californians, including all income eligible adults age 26 through 49. This would round out really the piecemeal process that we've had over the course of the last couple of years to expand coverage to all Californians. So despite all of this progress, we still have some work to do. And so as part of the governor's budget, we're also proposing to eliminate monthly premiums for individuals and families to provide additional financial support. So despite the coverage expansions that we have, the existing law still requires certain Medi-Cal beneficiaries to pay a monthly premium. This includes individuals and families that are already living on limited incomes and individuals with disabilities. So the monthly premium payment requirements creates barriers in access to care, and in many instances can lead to unnecessary breaks in coverage for eligible individuals. So the governor's budget leans in further by eliminating these premiums for a subset of individuals, which we're really, really proud of. The governor's budget also does one additional thing that I think is really important, and that is it extends the suspension of Medi-Cal benefits for just as involved individuals for the full duration of their incarceration, so that the individual maintains that Medi-Cal benefit when they are released. And this is important from a continuity perspective because our eligibility workers at the ground don't have to take someone off the Medi-Cal program and then re-enroll them once they get released from jail or prison. And so the fact that we are continuing this work and having this seamless system is going to be quite important with this proposal. And one thing to note here is that just as involved populations experience, as many of you know, and I don't have to repeat this, but just as involved populations experience a disproportionate high rates of physical and behavioral health diagnoses. So continuing or creating this continuity of care is vital to in many ways reducing recidivism, promoting positive health outcomes, and ultimately creating a successful opportunity for reintegration into our community. So in addition to those efforts or those building blocks that we've really worked on together, both the administration and the legislature and all of you in the community who do this work day in and day out, we're also reimagining the delivery system. So we've covered all these individuals. And I often say that it's great if you have health insurance coverage, but if you don't have access to care, or if that care isn't provided in a quality way, then the impact of that coverage is not great. And a way to hit home on this is if a kid goes to a pediatrician and gets a prescription for an antibiotic, but they go home and there's no food on the table and they can't take that antibiotic with food, the effectiveness of that antibiotic goes away. And so we have to really think about this the coverage component as piece of a broader puzzle. And so really thinking about how do we reimagine the delivery system? And so we're really proud of our work on CalAIM, which really looks to transform the delivery system and provides a set of community-based services to build on top to address some of the social determinants of health more broadly. Also, the Department of Managed Healthcare has been doing some tremendous work with stakeholders around quality and equity. And I think looking at ways in which we hold health plans accountable to make sure that we meet certain benchmarks furthers this goal of integrating, but also improving and reimagining the healthcare delivery system. So really excited work in both of those spaces. And then finally, we're working on this once in a generation effort around our reprocurement of our managed care plans. And really that is intended to look at ways in which we improve the delivery system from both an accountability perspective, a transparency perspective, a quality perspective, and an equity perspective. All of those pieces really get integrated. As I alluded to, really coverage, delivery system reform, payment system reform are pieces of this broader puzzle. And if you look at California, and if you were to look at kind of the individual, we're really trying to puzzle this together with other initiatives, whether it's our work on behavioral health infrastructure or our work on public health infrastructure, our health and human services information exchange, the way data gets shared, or our workforce initiatives that we're looking to launch. All of these things, one other example or one other piece of the puzzle is our home and community-based services and the waiver that we submitted to the federal government. All of these pieces come together in service to the individual. And we're just really proud of the work that we've been able to do over the course of the last couple of years. For many of you in the community, you've been doing this work for decades. And so we are just building on your good work and in partnership with you. I want to close just my remarks, and I'm really stoked to hear from Kathy and Dr. Arambula. But as we close out Women's History Month, I really want to take a moment to acknowledge an individual who I have been inspired with. And many people don't know about her, but her name is Dr. Molly Orshansky. And I will tell you why she's so important to this work around coverage and other pieces. Dr. Orshansky actually moved to Washington from New York in 1936, I believe, to be just a junior statistical clerk at the US Children's Bureau at the time. Later, she moved on to be a family economist at the US Department of Agriculture, where she really studied family food consumption and looking at how families really consume food in the United States. In the late 50s, she joined the Social Security Administration, where she really worked on poverty. And at the time, there was really no measure of poverty. And so she looked at ways in which you can calculate poverty or measure poverty or income inadequacy in the United States. And in 1963, she was assigned to a project looking at poverty among children, and she published a paper around really the work around the implications of poverty on children. And in that work, she really created a poverty measure looking at kind of the economy food plan at the US Department of Agriculture. When the president in the 60s, President Johnson, declared a war on poverty, the Council of Economic Advisors realized that there was this woman who was a silent public servant and had developed this measure of poverty. And the White House decided to ask her to build that out for the entire United States. And in the late 60s, it was adopted as the official poverty threshold by the US Census Bureau. And today, still, this measure gets calculated on a yearly basis. And the US Department of Health and Human Services uses it to create the poverty guidelines, which we then use for a number of our various programs, including our insurance coverage for the Medicaid program. And I close by this because she is just a lone public servant who had profound impact on the work that we do each and every day. Her statistical work and her creation of the poverty thresholds are the way we do business today and is what fuels us to do the good work. Dr. Orshansky also is an immigrant from the former, from what was before the Ukraine. And so as we kind of look at the world situation at the moment, I'm also just reminded that many of you and many of Californians who are immigrants to this beautiful state have had tremendous contributions to the health and well-being of this state. And so I just want to acknowledge the many individuals that are in our communities who are immigrants or refugees who have had a profound impact on public policy in the state of California. So with that, Katie, I just want to say a huge sense of gratitude and thanks to you for your leadership. I want to say thank you to the partners who are on this call. And I'm just really excited to have a brief conversation with you and then really listen to Dr. Arambula and Kathy for their remarks.
Marco, thank you so much for those opening remarks. And I do want to appreciate you talking not only about everyone on this call, our individual contributions, our collective contributions, collective partnership over the decades to get here, as well as people that we don't know, and for introducing us to someone new who was part of this effort. And certainly not least of all yourself. So thank you so much for that. As you said, part of this is really exciting because I know most of us on here are very supportive of the direction that the state's going, and that's why we called it a culture of coverage. This really feels like a watershed moment to all of us and all those who came before us and all of us going forward. So, and we know that there's a lot more to do. So today we're just focused on the expansion of that coverage and getting people into coverage. And we know we've got a lot more to talk about, many future ITUP events about making that coverage as meaningful and accessible and equitable as we can. So I'm looking here, I want to invite the audience. If you have a question for Marco, we have, I think, time for just one question. I am seeing in the chat, do you have a link to find information about the doctor and name spelling? Marco, if you could send us, either pop that in the chat. There we go. Thank you, Dr. Molly.
And when I was at the U.S. Department of Health and Human Services, we actually wrote to not forget her. She passed away in 2006. A colleague of mine, his name is Gordon Fisher, spent many years having Dr. Orshansky as his mentor. We actually wrote up a biography of her that I will send to Katie, and Katie can share it with you. It also is something that was published in the Social Security Bulletin a couple of years in honor of her work and dedication to public service.
Wonderful. Marco, thank you so much for being with us this morning. I'm going to take a moment and we're going to switch out screens and we'll turn it over to Kathy. Marco, thank you again. Kathy, welcome. We have Kathy Sunderling McDonald, who's the Executive Director of the County Welfare, now I can't remember, Kathy, County Welfare Directors Association of California. And so pleased to have you here, Kathy. I know you've been with CWDA for many years. Excited for you in your new-ish role as Executive Director. You've just been such a light and a leader in this area, and can't wait to hear what you have to say. So welcome. Thank you.
Great. Thanks so much, Katie. Hi, everybody. It's nice to not see any of you on this call other than so far Marco and Katie. Thanks for the kind words, Marco. They're returned as far as the partnership that we have with agency and you personally. And I also can't wait to hear from Dr. Arambula in a few minutes after me. Thinking about the culture of coverage as I get started, I want to remind folks of where we were before the Affordable Care Act went in. We had about 9 million people, a little under 9 million people on Medi-Cal, and the rules were very different, especially if you were an adult who didn't have children or didn't have a disability or were not aged. You pretty much could not get on coverage, and because it was just not allowed. And so one of the things that I remember talking with our eligibility staff about, I did a set of focus groups after the Affordable Care Act was passed, and kind of in the run-up as we in California were working on the policies and processes that we wanted to put in place. And they were really looking forward to going from this very compliance driven, dot every I, check every box. And often, so often, the answer was no, I'm sorry, I don't have anything for you. They would talk about people crying in their offices who were ill or who had family members who were ill who could not get on the program. And there was literally nothing they could do. And the idea of being able to say yes, to say, we have something for you. There is going to be something here for you, whether it's in Medi-Cal or the exchange, later renamed Covered California. The anticipation was just tremendous. And what we did in California, as Marco noted, was we got a head start. We were able to enroll almost 1 million individuals, the adults who'd not been eligible for coverage previously. And then at the point when the Affordable Care Act went into place, we could essentially lift and shift them from a county-based waiver allowed structure right into the ACA. I mean, that gave us a huge head start on the success that we saw. And through the efforts of counties, the local assisters, the state, and all of our assistants, counties were able to enroll a total of about 5 million new people, and we peaked around 13.5 million. And I'll say, I never really thought we'd see that number again, at least thinking about recessions, I kind of hoped we never would. And then, of course, the past 2 years happened, and we've held individuals on the program, something I'll be talking about, kind of what happens when that stops. And we're now around 14 million people on Medi-Cal. So we're back up to that peak, that historic peak. And that's about, as you know, 1 in 3, a little over 1 in 3 now of those in California. It's pretty amazing. It was, I think, a literal lifesaver over the past 2 years for people. So many people who had uncertainty with their jobs and lost jobs or left jobs to preserve their own security and health as they had to be able to fall back on that coverage. So I want to talk a little bit about a couple things that are coming. As Marco talked about, I'll give some perspective on the expansion to undocumented populations, the Health for All expansions, and then also talk a bit about how we're preparing for the lifting of the public health emergency. Even though we know there's still variants and there is still a degree of infection and hospitalization and even deaths, we know those numbers have gone down tremendously, and there is anticipation that that public health emergency will soon be lifted at the federal level, and we'll need to start processing cases that we've largely been able to set aside and ignore changes for the last 2 years. So first, thinking about Health for All, I mean, it's just about getting more people on the program and on full scope coverage. And the counties will be, along with our information technology partners at the CalSAWS system, the system that counties primarily use, will be starting work in just a couple of weeks to line up these cases for our May 1st start for the coverage expansion for those 50 and older. I will say, when we talk about those as older Californians, I am 49, so it does kind of stress me out a little bit, but 50 and over, it was great to have that larger population end up getting included. And so what we call these are batch processes. Remember, I said lift and shift. What we did back in 2014 with those almost 1 million people was there were these procedures that the IT systems ran, boom, boom, and try to get as many people in without ever having to have a county worker push a button or do something with that case until later on when they had a renewal due or a change in circumstance, just like any other case. And so we're hopeful that most of the people will successfully transition. What we always see with these batch processes is that some people don't successfully make that automatic transition. There may be issues with the case, blank fields and the data, changes that are kind of pending. We don't really know what percentage will happen, but that's why we start early, why we're starting in early April, so that the counties can do that manual work on those, that they'll get lists and these lists will say these individuals did not successfully transfer, the counties can go and work on those individuals, contact them, clean up the case, add in new information, whatever is necessary. So we can get as many people as possible in that very first May 1st date and have their coverage turned on. In addition, there's going to be outreach, of course, to enroll more. It's not just the people who are in the system now. And so counties are working with clinics to conduct outreach as they see many of those who are uninsured today. Community health fairs, they have outstation workers at various offices and agencies that we share, customers with. They are going out with outreach teams to rural communities, to farm workers, to homeless camps. They work with food banks, faith-based organizations, senior centers, COVID vaccination clinics, a location we didn't have 2 years ago, and with organizations that work with immigrant populations and school districts who are really very important as partners because they not only see children in these families, they also work closely with their parents and often have language skills or other information that they can, sort of provide that trusted partner type of information. On an ongoing basis, we know that there's going to be that further expansion that's proposed, technically needs to be adopted, but there's not a real concern, of course, that that won't happen in this budget that's coming up for those in that kind of middle age group that Marco is talking about. And so we have wanting to make sure and working along with the state and our managed care partners to make sure that the timing of implementation allows us to maximize the availability of care, to minimize chaos of doing this right at the same time as the PHE lift, which would be pretty difficult to manage, quite honestly, given that we're running 14 million people through that process. And we really want to make sure that the work is done properly and allow for that good outreach to occur. One of the things that I was asked to kind of touch on was the question of where we are right now with concerns around public charge. I mean, of course, many of you are familiar with what happened in the prior federal administration. People were really whipsawed between different areas and different kind of proposals. And really, it was less about who public charge affects, which is a relatively small proportion of our immigrant population, but how to scare people away from using programs for which they're eligible and for which the need is there and the need is great. In talking with counties in preparing for this, we do know that the fears are still out there, though they mostly reported that it's not as prevalent of a set of concerns as it was during the prior administration. But it's a complicated issue. There is confusion. There is sort of a continued lack of trust, and all of the changes back and forth over the last several years and just the public attention and the media attention have made it more so. And so even though county eligibility workers can't give legal advice, they do refer to the legal aid groups, which we really appreciate. The state continuing to fund, and they partner with CBOs who work with these populations to provide accurate information in targeted languages to potentially impacted communities. We do think it would be a good idea to invest in some additional messaging and public education on this as we do this year's expansion and as we look out to additional years. And of course, we will be happy to work with the administration, foundations, and others who may be interested in doing that. And then regarding the PHE lift, that's about keeping people on who are eligible. And we're still not sure exactly when this is going to occur. The federal government has committed to give states a 60-day notice. We're already at the end of March, and the current PHE period goes until mid-April. And so we would not expect anything sooner than, if you think mid-April to mid-May to mid-June is about 60 days. And so mid-June at the earliest. The other thing, though, is that they've been doing these in 3-month chunks. So you might even see it go out to mid-July. It's unclear yet, but we'll know very soon, within the next 2 weeks, what's going to happen. I will say as well that CMS at the federal level has issued voluminous guidance to states The state is currently working closely with partners. Counties are included at the table to kind of translate those materials into what are we going to do and how are we going to operationalize that. And I know that those materials will be made public, which is going to be very helpful. The important things for people to know is that nothing is happening immediately and nothing is happening all at once. The federal government has given the states up to 14 months to conduct eligibility renewals for the individuals who are on our caseloads. And so how we're looking to do it in California is everyone needs a renewal every 12 months. And so as their renewal comes up on the regular schedule, what they would be doing a renewal anyway, we will then process that case and take care of any changes. And so the idea is that people will just go along until their next renewal period and not have any changes until that happens. And so remember that the post-Affordable Care Act process is actually different than the pre-Affordable Care Act process on how we do renewals. And not everyone realizes that. So I think it's important to take a minute to explain it. The first thing, and it starts a couple months before the renewal is even due, our computer system runs out all the data that they have on that case against federal sources and tries to automatically renew the person. And if that works, if the information they get back is sufficient and consistent with what we have, we send out a letter that basically says, you're good. You got 12 more months. We don't need anything else. Here's the information we used. If for some reason that's wrong, feel free to tell us. But there's no really requirement. If that auto renewal process does not work, that is when a packet, we need more information, is sent out to people. And then they're given time to respond. There's a 10-day notice prior to discontinuance if someone either does not respond or responds and it turns out that they're not eligible. And then there's even a 90-day cure period, which is longer than it was pre-ACA, for them to come back and actually reinstate coverage. There's a few key issues to be aware of here. First is potential loss of contact. It's been 2 years. And so we're trying to send the message of update your information if it's changed. If it's not changed, people don't need to contact their worker. If they've been getting information from the state or from the county during the last 2 years, not every single person needs to call the county, only people who've moved or have other information that's changed. Certainly the contact information is critical. There's going to be confusion over whether to respond. People have had renewals done for them over the last 2 years. It's an automated process, and we were directed by the state to continue doing that, to automatically renew as many people as possible. That meant that people have still been getting paperwork, and those of you who are here in the audience who have been assisting people to say, don't send it in, don't worry about it, nothing's happening, you're not going to get kicked off, the messaging needs to change. It's critical that we work together and have consistent messaging. The other thing to know is that the auto renewals may not happen as cleanly or as successfully as they have in the past. We've been running, around half or even a little more, depending on the county, of people getting automatically renewed. And that's been great over the years, but it's been 2 years. A lot of people have changed jobs. A lot of people have moved. People have had babies. People have, changed. And so we need to make sure that we kind of are ready for those changes. And then finally, I just want to say, counties are staffing up, and it's going to be really important that we work with CBOs and our managed care partners, who are all going to be considered real ambassadors and message senders to be able to make sure that we're not losing coverage, especially for people who remain eligible. I think I'll wind up my comments there, especially because Katie's back to make me do that, and see if there's any questions that I can answer.
Kathy, thank you so much for that. There's so much there. I actually don't think we have any questions, but our chat has been extremely active while you were talking. Some highlights are particularly addressing the fear of public charge, which I know is front and center for everyone. And so it's wonderful to hear you talking about that and knowing that counties are prepared to have that conversation and share those resources and connect people. So we're going to make all of those available on our website so that all of our folks here listening can access those and send them out to their networks. So thank you for that. And thank you also for reminding us, just taking a moment and reminding us where we came from. I know when I started this almost 2 decades ago, we were at 8 million people in Medi-Cal. Now we're at 14 million. And 50% in managed care. We're almost at 99% managed care. So just incredible work done.
Absolutely. Glad to be here. And to the extent that folks have questions in the chat, we can certainly get those and try to help address those later in a Q&A and work on the sort of making sure that the materials are available and helpful to people. Thanks for the opportunity.
Kathy, thank you so much again for joining us, and best of luck in all of the work that you have ahead. So much to do. Yes, so much. Thank you. And with that, I'd love to turn it over to Assembly Member Joaquin Arambula. Dr. Arambula, you've been such a champion for this issue for many, many years. I'm sure prior to the legislature and during your work in the legislature. So would love to hear from you today. Celebrate, the exciting work that's been done and where are we going? So please go ahead. Thank you for being with us.
Thank you so much. It really is an honor to be here today at the ITUP conference and to be joined by panelists such as Marco Mijak and Kathy Senderling McDonald. It's important, if I can take a moment of personal privilege, to actually identify many of the organizations who lit the inspiration inside of me to come and serve the public good by running for office. It was actually at an ITUP conference that I first came to Sacramento. I was listening to then Congressman Javier Becerra talk about the need for us to expand coverage, that I became inspired to want to leave my practice where I was working in Selma. For those of you who don't know me, I spent 10 years working in the breadbasket of the world. Selma's the raisin capital of the world, and took care of many of our farm working communities. And I saw firsthand the injustice that occurs to our immigrant communities when they are excluded from our healthcare system. I am so pleased that we have a culture of coverage here in the great state of California, and that we have a legacy of leading, as we have done in 2015 to expand healthcare coverage to kids, in 2019 to young adults, and 2021 to our elders and seniors. Now we have the tough work of implementing and enrolling and ensuring that hundreds of thousands of our Californians who are vulnerable and exposed will have coverage starting in May of this year. I look forward to the continued collaborations between our county partners and state administration to ensure that we're doing everything we can to enroll people. But I will highlight, if I can, that the Health for All movement, which is being led by Health Access and the California Immigrant Policy Center, as well as many other organizations, needs us to ensure that we are going to have AB4 signed, as it will help us to protect those provisions in state statute so that we can ensure healthcare access for all. I'm looking forward to those continued discussions as we go forward this year to ensure that we both expand the coverage, but are advancing and innovating Medi-Cal as well. I was excited to hear Marco talk about CalAIM and the important investments we're making to address many of the social determinants of health. I will take a moment, if I can, to also uplift some of the other bills my office is working on. Included in that is AB 1900 to address that you shouldn't be paying 60% of your income to be able to access healthcare. We are working to ensure that many of our elders and people with disabilities, tens of thousands of Californians, will be able to have their share of cost adjusted by us working on this bill together. I want to uplift as well as echo what Marco had said on AB 1995, which will continue what the governor has in his budget, but allow us to eliminate many of the monthly Medi-Cal premiums as well as co-payments that our pregnant women, children, and again, people with disabilities face. We must continue to figure out how to deliver a better product. And I'm excited that we are here in the state of California where we're continuing to innovate, to expand, and to be inclusive of all. I really want to uplift, if I can, Marco's words about acknowledging the impact that immigrants have had in making this great state what it is. I think it is an acknowledgement that after having gone through this pandemic of the century where we called people essential, it is nice for us to take care of their essential needs now as a result of that pandemic. I'm looking forward to how we actualize and operationalize and implement, as that is where equity is built in and look forward to many of the organizations who are on this group to continue to advocate and to uplift the needs of our immigrant communities. I'm grateful for being invited to participate in this panel. I'm happy to take any questions, and again, just want to thank ITUP for continuing this conversation, for beginning for so many of us a way in which to engage and to make change in our communities. Thank you for having me here today.
Dr. Rambula, thank you so much for your comments and noting just how personal this is. I know we get stuck on the policy piece, but this impacts individuals and people that we all know and love. And so thank you for reminding us of that. We're just so grateful to have you here and appreciate, can't say enough about your leadership on this issue, as you know, and we should take a moment to realize just how incredible this is, but just how much work we have to do, as you said, to actually actualize and make this a reality. You know, it's one thing to say we have this on paper, but it's another thing to actually enroll people and get them into coverage and make it as equitable as and accessible as we can. And there's been some really incredible comments and notes in the chat as well. So celebrating all of the work. Just in case you didn't see that, yes, thank you so much. We're so grateful. I'm not seeing any questions here, but just again, a lot of wonderful resources shared. Thank you everyone who's sharing them. Please continue in the chat. Dr. Rambla, I think we'll say thank you. You're welcome to stay on, and we're going to move on to our next panel. So thank you so much again for being here. So it looks like everyone on our next panel has turned on their videos. If you haven't yet, I will invite you to do so now. I am so excited to introduce you all to our state policy leaders. You know, as both Marco, Kathy, and Dr. Rambula all said, every one of us probably listening to this forum today has had some hand in this, and we just wanted to uplift all of the incredible work of the last 2 decades of many of these organizations that you're going to hear from now. I'd like to take a moment and introduce our moderator, Amy Adams, who's a senior program officer with the California Healthcare Foundation. They, of course, as you all know, have been doing incredible work in this area, and I know Amy is going to lead us through some wonderful questions and let our panelists introduce themselves and talk about the work, but also try and uplift some of the systemic issues that we know exist in trying to enroll and get across the finish line. So Amy, I'll turn it over to you. Thank you so much for agreeing to do this and being here.
Great, thank you, Katie. Can everybody hear me all right? Terrific. So before we dive into the panel, I just wanted to say how much I appreciated sort of the comments and the recognition of the progress that California has made in this area. You know, since the ACA, really, you know, tremendous work, and always really important for us to remember sort of how things were, right, and how far we've come, and to celebrate that. And at the same time, we find ourselves at this historic moment, right? And I think we all agree there's a lot needed to make the progress of this coverage expansion real. Thinking specifically about the outreach and enrollment piece, which Katie asked me to comment on, you know, we know a fair amount about the challenges that exist for Californians when it comes to enrolling in and keeping their coverage. Last year, CHCF partnered with Vision, Strategy, and Insights to conduct focus groups in English, Spanish, and Mandarin so we could hear directly from uninsured Californians who are eligible for Medi-Cal about why they don't enroll. And the folks on this panel, they hear this, they hear this all the time, right? And they know this. You know, those of you in the audience, if you're interested, you can read the findings in our report, which is posted on our website. It's called the Medi-Cal Maze, and it includes some policy recommendations. But just to, you know, kind of underscore some of the common themes. And these are perennial issues, right? People talked about unanswered questions, challenging and confusing reporting requirements, particularly around income, misinformation, feeling frankly outright disrespected and unwelcome in some situations. People talked about the need for better in-language assistance, for plain and simple communications in their own languages, fewer and clearer documentation requirements, better handoffs between Covered California and Medi-Cal, and a way to track the status of the application along the way so you know what's happening. And then again, I want to thank Kathy for underscoring this point. because in this research, as we have seen repeatedly in other research, today, immigrant families really wanted to know that they were not jeopardizing their future immigration status by enrolling in Medi-Cal. And they wanted assurances that the sensitive information that they're sharing with Medi-Cal would be safe. So just to be clear about all this, these barriers are not naturally occurring, right? They're the product of specific policy and program choices that we make. They're not new, but as we are on the verge of this huge opportunity to make Medi-Cal truly an inclusive program, I would say that addressing these issues is more urgent now than ever before. So with that in mind, we're going to turn to our fantastic panelists who are going to talk about how California can make the right policy choices to make this promise real. And just to describe the format for a second, we're going to hear very briefly from each panelist who's going to describe the key issues that they're focused on when it comes to the 50 and older expansion, with an eye toward also thinking about that potential larger expansion when we remove immigration status as a barrier for all income eligible Californians to Medi-Cal. So after everybody has had their brief turn, then we're going to open it up for questions and discussion. And I really hope folks, please, from the audience, please share questions. Thanks. And we're going to start with Anthony Wright, Executive Director of Health Access California. So take it away, Anthony.
Hi there. Thank you, Amy, and thank you, ITUP, for inviting me and all these great leaders in California that we are blessed to have. Again, I'm Anthony Wright. I'm the Executive Director of Health Access California, the statewide healthcare consumer advocacy coalition, working for 35 years on the goal of quality, affordable healthcare for all. And at no time in those 35 years have we been this close to that goal. We've mentioned that, just last week we had the 12th anniversary of the Affordable Care Act. And more than expanding coverage to millions of people, more than providing new patient protections to millions of Californians and Americans, I would posit that maybe even the most important thing that the Affordable Care Act taught us is that progress is possible, that this big, thorny, complicated issue that had we actually show that we can actually make a difference. And here in California, we took one of the highest rates of uninsurance in the nation, close to 20%, cut that in half, had the biggest drop of the uninsured of all 50 states due to the leadership of many of the folks on this Zoom. But we cannot use that to rest on our laurels. We can use that as inspiration for the work that we have yet to do. We have to remind ourselves why this is important. There are issues once people are in coverage of access and affordability and network adequacy and cultural competence, but coverage is fundamental. And let's remember that if people are uninsured, they live sicker, they die younger, they're one emergency away from financial ruin. And that's the project that we're undergoing is to prevent that situation where we have millions of people uninsured. And what we have before us today at both the state and federal level, we have policy decisions that will impact whether over 1 million people are covered or not. Some of those are at the federal level with regard to whether we extend the assistance that is currently being offered in Covered California. And at the state level, we have a package of bills, most notably the expansion of coverage to all, regardless of immigration status in the Medi-Cal program, that would be the biggest expansion of coverage since the passage of the Affordable Care Act, over 700,000 people. It is hard to just wrap your head about how big that is. We should also just take a second to recognize how big this is on the scale of the nation. That, I was told in friendly competition with our with my fellow advocates in New York that New York is about to take inspiration from what we've been doing. They have a campaign not called Health for All, but called #CoverageForAll. And they're very explicit that they've taken a lot of inspiration for us. A lot of their materials even cite what California has done. And they're on the precipice of passing their expansion of their Medicaid program for all, regardless of immigration status. And that would cover 150,000 New Yorkers. What we're doing just with the 26 to 49-year-olds is 700,000 people. So just give you a sense that everything in California we just do, and we just do into such a bigger scale. And that does mean issues, including some of the issues that Kathy talked about with regard to having to do this implementation, having to do it right at the scale and the diversity and the complexity of California. But I think that's really important. And I also very much take our champion, Assemblyman Arambula's admonition that, the job's not done, that we have to get this expansion signed. And I would even posit not just signed, but started, because that makes it real. That makes it real for people on the ground. And we would like to get that started sooner. And I think there's conversations about how we can move forward, not just because we want to beat our friends in New York, but because there's people who actually need the coverage, who especially in the wake of a global pandemic. Our healthcare system is stronger when everybody's included, and nothing like a pandemic to make it realize that our healthcare is tied to that of our neighbors, that of our community. Our health, our economic vitality is tied to one another. I'd be remiss if I just didn't mention before that the Health for All expansion is not the only thing that is a step toward the goal for universal coverage. I'm also proud, in addition to co-chairing the Health for All campaign with our friends at the Immigrant Policy Center, who will speak momentarily. We also are happy to be in coalition with many of our partners on a coalition called Care for All California, which is about the many steps that it would take to get us toward the goal of universal, equitable, affordable coverage. And so it's not just expansion of 700,000 in Medi-Cal, it's about providing greater affordability assistance in covered California, but both by extending the federal help that's being provided now, but also by building on that federal effort to try to use our state subsidies to try to reduce burdensome cost sharing, including potentially eliminating deductibles for the over 1.8 million people in covered California, for the most of them. Pending in the legislature today are bills that by Chairman Pan and Wood to provide that greater affordability in covered California. There are efforts by Assemblymember Arambula to lower cost sharing in the Medi-Cal program for seniors, for children, for people with disabilities. I know my colleagues will talk more about that. And then so I think that these are all steps that get us closer to that goal. And then the final piece is I want to just say is that I think part of our work is about access, removing explicit barriers, but it's also making our coverage accessible, but also affordable, and frankly, automatic, administratively simple. And so I'm glad that we have bills this year, again, with some of my partners on bills to try to connect people while they're filing their taxes into coverage, when they're filing for unemployment, when they're going on strike, so I'm trying to make sure there's continuous coverage when people are in different programs. I'm happy to put in the chat the Care for All website, which has a list of those bills, and happy to go more into detail. But I'm excited about how all these steps together can get us to the goal, while we're also having the broader conversation, how do we get to a fully universal system? I'm proud to be on the Healthy California for All Commission that is currently pondering right now. There's just a draft report out that a draft final report of fleshing out what that vision would look like. And I think that's a really important conversation that we had earlier this year with AB 1400. We need to continue it, but we can't let that get in the way of the urgent things that we can do now. And that's what I'm excited about what we're talking about in this panel. Thank you.
Thank you, Anthony. I love that. Progress is possible. It's going to be our slogan. The next up is Tiffany Wynn Cho. She is the Senior Staff Attorney at Justice and Aging. So I will turn it over to you, Tiffany.
Thank you, Amy. Hi, everybody. I am Tiffany Wynn Cho. I use she, her pronouns, and I'm honored to be part of this event and speak at this panel. I am a senior staff attorney at Justice and Aging. For some background on those that aren't familiar with my organization, we are a national legal advocacy organization. Our mission has been to fight senior poverty by increasing and improving access to healthcare and economic security on behalf of low-income older adults. In fact, we are celebrating our 50th anniversary later in April. We primarily focus our efforts on populations that have been marginalized or excluded from justice, including women, people of color, immigrants, LGBTQ, limited English proficiency, and those with disabilities. As part of my work on the health team, I also co-chair, along with the National Health Law Program, a work group made of several advocate organizations, and several of whom I've already seen in this meeting already. And this work group works very closely with the Department of Healthcare Services on the upcoming expansion of full scope Medi-Cal to those that are 50 and older. I'm truly excited to see this important expansion of coverage. It provides momentum to move towards future expansion. And in the immediate term, it reduces the number of uninsured Californians, especially for undocumented individuals who are also barred from coverage through Medicare and the covered California marketplace. The most recent numbers our group received from the state is that about 244,000 individuals will be moving into full scope Medi-Cal starting May 1st. This is a huge number. It reflects those that are on emergency or restricted scope Medi-Cal now, which is, the limited benefits that, this age group is only eligible for right now. So again, it is a large number, and it's only a fraction of those that could be eligible, because this 244,000 number only reflects those that are currently on the restricted scope or emergency Medi-Cal. So with May 1st coming up quickly, some key issues that I've been thinking about is the continued need for outreach and awareness of this expansion. And on this, I mean, there will be a continued need to raise awareness of the expansion for those that are not yet connected to Medi-Cal benefits. And that could be due to fears about public charge that has been, addressed multiple times already, the limited benefits that restricted scope Medi-Cal offers, and for those that will be turning 50 in the coming months and years and becoming eligible for full scope Medi-Cal. So the need for continued awareness of the expansion also means a need for funding to support local efforts to provide outreach and public education on the expansion. Other key issues that have come up time and again as we prepare for May 1st is, very common eligibility questions. Public charge is always a concern. Like Kathy highlighted, there's been a lot of, policy changes in the past, years about public charge, and a lot of misinformation and distrust still continues. There's also privacy concerns with, the sensitive information provided to county workers, and even just basic general eligibility questions continue to come up about how to qualify for Medi-Cal, how to report fluctuating income, what counts as income, as well as concerns around language access itself. So like others have highlighted, these are ongoing issues and impact the reality of policy decisions on the ground. The good news is that these issues are not insurmountable. We can all work together to make coverage and access to care a reality for all. Thank you.
Great. Thank you so much, Tiffany. Terrific. We are going to turn to Corey Rosella, Deputy Director at Western Center on Law and Poverty.
Thank you, Amy. As she said, I'm Corey Rosella, Deputy Director of the Western Center on Law and Poverty and a health attorney. Western Center is California's oldest legal aid support center, and our work focuses on securing healthcare, housing, public benefits, and access to justice for Californians living in poverty while centering equity and racial justice. We are also a member of the Health Consumer Alliance, which has been mentioned throughout the chat this morning. Thank you, Alicia, for posting all of our older adult expansion materials. The Health Consumer Alliance is a consortium of legal aid programs that run a statewide health hotline that provides free legal help in all counties. With the older adult expansion, as with the children's and young adult expansions, and really all of our Medi-Cal eligibility work, we are focused on working with our legal aid and community partners to identify issues that need systemic advocacy and conducting administrative advocacy with the Department of Healthcare Services in the counties to make sure implementation rigorously promotes and protects an individual's rights. Two of our legislative priorities this year are related to making Medi-Cal accessible and actually affordable for older adults, which is an important foundation for the older adult expansion and the eventual, I hope, full expansion. Historically, public benefits programs have been strictly reserved for the so-called deserving poor, and that meant very punitive eligibility rules designed to be a barrier to enrollment, which have roots in racism and have a disparate racial impact. While the ACA did away with two major eligibility hurdles through Medicaid expansion and the elimination of the assets test for MAGI programs, it did not really touch on non-MAGI eligibility. So Western Center has been working for the last several years to bring eligibility parity for older adults. And I have to give credit to our budget advocate, Linda Way, and our former policy advocate, Jen Flory, for their tremendous work on this, as well as David Kane for his leadership and implementation. Thanks to a bill we sponsored last year, this year we will see a dramatic increase in the assets limit before the assets test is eliminated altogether in January 2024. To deny Medi-Cal based on assets is really to punish people for saving at a time in their lives when they need to rely on savings the most. And we are so thrilled that this massive eligibility reform is happening at the same time more older adults are coming into Medi-Cal without regard to their immigration status. And this year we are co-sponsoring two bills that Dr. Arambula authored and mentioned earlier today aimed at the share of costs and Medi-Cal premiums. AB 1900 would raise the maintenance need level, which is the basis for determining share costs, to be tied to 138% of the federal poverty level. So that would mean if your countable income is over by $1, your share of cost would be $1. The maintenance need level has not changed since 1989. And as we all know, the cost of living has very far outpaced that. We're co-sponsoring that bill with Beth Zedek, Canner, Disability Rights California, Justice and Aging. Our other bill in this area is AB 1995, which we are co-sponsoring with Children Now, which would eliminate Medi-Cal premiums in the 250 Working Disabled program and for children above 160% of the federal poverty level. Share of cost reform and the elimination of Medi-Cal premiums are the latest in a long line of eligibility victories we've worked on, including estate recovery improvements, raising the federal poverty level limit for the age blind and disabled program, and fixing the yo-yo problem for dual eligibles. We believe that dismantling these eligibility barriers for older adults lays the groundwork for this year's Medi-Cal expansion and secures a future of eligibility continuity for the full adult expansion of Medi-Cal. Thank you.
Thank you so much, Corey. We are going to turn to Kiran Savage Sungwan, Executive Director of the California Pan-Ethnic Health Network.
Thanks, Amy, and thanks, ITUP, for having me. It's a pleasure to be here with my good friends and colleagues on this panel. And a lot has already been said, but just briefly, my name is Kiran Savage Sungwan. I'm the Executive Director of the California Pan-Ethnic Health Network. We are a statewide multicultural health equity organization, and we've been working for 30 years to dismantle systemic and institutional racism in healthcare in the state of California by working with community-based organizations and grassroots organizations across the state who are deeply embedded in communities of color. And, you know, I think the first thing, as has been said today, is really want to celebrate the tremendous progress and really want to, I think, particularly recognize all of our community members and individuals who shared their own personal testimonies, their own lived experience, sometimes at great personal risk, to really make these things happen. I think the fact that we have communities that have that kind of bravery and resilience is really a testament to our values in the state of California, and as is really the sort of pivotal element that has made this progress possible. And we're really excited to see implementation both of the older adult expansion in Medi-Cal and of the full expansion in Medi-Cal. But I do want to sort of return to some of the comments that Amy and Corey made about sort of how the system as a whole, how health coverage in the state of California, and not just the state of California, but the United States as a whole, is sort of set up, and that we've created for ourselves a very complicated system that's not really designed around people, right? It's not really designed to get people covered and to get people access to healthcare. And so I appreciate the work that's happening in the state of California with the Healthy California for All Commission to sort of think about what are different ways we could design this, what are ways that we could remove those systemic barriers and really create a culture of coverage where we live up to the value that everybody's in and nobody's out, right? I think one of the things that is important for us to acknowledge, even with the tremendous expansion in Medi-Cal, which is, I believe, the single most important thing we could do, that still doesn't get us to universal, and it doesn't even get us to universal for our undocumented community. I think it's important for folks to understand our undocumented community in California is incredibly diverse, right? And we have people of varying income levels, with people who are going to miss out because they make a tiny bit too much money to be on Medi-Cal. And we haven't yet been able to obtain the right permission from the federal government to provide people sort of that safety net of covered California as an alternative. And so that's going to be a really important step for us. It's also really important, I think, for us to understand the number of undocumented residents who live in mixed status families, for whom some of this is going to be very confusing because different family members are eligible for different types of coverage. And so really making sure that we are able to explain to people their coverage options, to help people understand how this will impact their entire family. Because what we understand too about access to healthcare is kids are more likely to access healthcare when their parents have coverage too, right? And when we have a whole family unit that's accessing the system. And finally, you know, understanding how diverse our undocumented community is. We have over 200 languages spoken in the state of California, right? And that we really are going to need to lean into and embrace that diversity as a strength when we're thinking about outreach, when we're thinking about enrollment, when we're thinking about really connecting with folks who are newly eligible, some of whom may have never accessed health coverage or public programs in California before, right? And so really recognizing those are significant barriers, and leaning into those means utilizing both our traditional outreach, but also non-traditional outreach, really thinking about who are the trusted messengers in communities who really have reach to communities that have legitimate fears of government, right? And of county outreach, and may need different strategies to engage them. In addition to sort of the work around making sure that we implement and cover our incredibly important, valuable immigrant community in the state of California, some of the other things that we really think about, one are that we have real difficulties in transitions of coverage, right? And Anthony spoke about this a little bit in some of the ways that we can make that easier. But what we saw with the pandemic is, you know, we rely heavily on a job-based health coverage system, right? And so whether or not you have coverage or what kind of coverage you have depends on your employment, which is really kind of, you know, not how we want to think about healthcare. And what we saw with the pandemic is so many people losing their jobs and yet not necessarily showing up in Medi-Cal or covered California. So I think we understand how important it is to really look at those transitions and to make for smoother and more automated processes for folks. And then finally, I'll sort of go back to Marco's point about, you know, coverage doesn't necessarily equal access, and that we really need to focus on the access piece as well. And that particularly with people who are newly eligible, newly enrolled, we really need to provide the community-based supports to assist people in navigating their coverage and understanding their coverage, in understanding what their health plan is and what their role is. Like, that's not something that's going to be automatic. And so we're really going to need to provide that support to people so that people actually are able to access healthcare and have optimal health outcomes. So I'll stop there because I know Sarah's got a lot to say on this topic too, but thanks so much for having me.
Thanks, Karen. Terrific. And we are going to our, I think the baseball analogy is the cleanup batter. Sara Dar from California Immigrant Policy Center. Sara, take us home.
Hi, everyone. I'm no good at baseball, but I'll try. Sarah with the California Immigrant Policy Center, or CIPC. We are a statewide immigrant rights organization that advocates for policies that uphold the humanity of immigrants while advancing racial, social, and economic justice through policy advocacy, strategic communications, statewide organizing, and regional coalition capacity building. So some of the things that I'm thinking about, and going last, there's no way I'm not going to repeat some themes here. So, but it's a lot of the things that people have mentioned at CIPC. What we are thinking about is these individuals and everything, all of the life circumstances in which they are situated, and how that impacts whether they're going to sign up for Medi-Cal if they now newly become eligible, but all the other myriad things that are going to impact it. And so people have talked about public charge a lot. I don't think there's any need to kind of keep hitting that nail on the head, but I think just immigration enforcement for these communities. In most cases, not being deported is like the #1 priority, and everything will come second to that, right? So even under the previous administration, that might even have meant just the travel to a community clinic, or where someone might be able to figure out some way to access care. Under the previous administration, people were literally concerned about being picked up by ICE at these places. So just thinking about reassuring people of their safety, and then public charge is also a piece of immigration enforcement, right? It's a concern that you may not be able to stay here if you're denied, permanent residency because of a public program that you accessed. And all of these concerns around enforcement, around my information being safe, around, my pathway to potentially being able to adjust status, all of that is, they are just discrete and distinct policies, and even different agencies in some cases that are carrying out those enforcement actions or making those decisions about people's status. But for an individual that's impacted by it, they mesh together, right? All of these concerns kind of build on each other. When you're hearing about one in the news, your fear about the other ones just becomes heightened and escalated, right? Especially based on the tenor and tone of who's in power at the time. So right now we're just thinking about how to inform and reassure communities to, we're in a different era right now. The Biden administration has updated their protected areas guidance that elaborates on and expands places where the Department of Homeland Security is committed to not doing immigration enforcement. And that includes community clinics, and they've expanded it to other sites of, domestic violence shelters and other service providers. But I think a lot of our communities, I would say most of our communities, aren't aware of this new guidance, of this new policy. So there's a lot of work to get the word out about that and just to reassure people. And so just even going upstream of like filling out the Medi-Cal application, I think it's all these other concerns and issues that are impacting these communities. And then people have mentioned, right, filling out a Medi-Cal application when you're an immigrant, especially someone who's undocumented, is in general going to be a much more complicated thing. We're talking about navigating language barriers, again, just feeling comfortable putting all this stuff down on a piece of paper and giving it over to a government agency. Income, I think several of my co-panelists have mentioned what income is and who in your household and how to count their income. If you don't have a regular pay stub, right? Your monthly income isn't a number that stays the same every month. It fluctuates. You might be a day laborer or a contractor. And so trying to figure out even to sit down and calculate what your income is can be a complicated thing. And then, who's in your household and, whether you're comfortable kind of sharing that information. I know for a lot of tax household is a lot of how your Medi-Cal household can be counted as, but if you're not someone that files taxes or knows who's in your tax household, that can be complicated. So all of that, I think I'm just adding more nuance to like what the problem is, and I know there's a whole room full of brain power here that's thinking through what the solutions are. But I think understanding the complexities and the nuances of the barriers and understanding the problem in all of its complexity, again, I think will help us come up with more tailored solutions, and they aren't going to be one size fits all. And I think that speaks to something that Karen talked about, community-based organizations. I know for us, especially the young adult expansion, and now we're gearing up for the older adult expansion, but some lessons learned from the young adult expansion. it was a lot of our grassroots partners who do other types of maybe immigrant rights work or other services they provide to the immigrant community. They were some of the ones that had the best reach into like undocumented 19 to 25-year-olds when we were trying to get them signed up. And so they did a really good job. They were at the front lines of saying, hey, we want to let them know that they're now eligible for coverage and get the word out. Can you give us some technical assistance on what we should be saying to them, right? And where we should be directing them. But a lot of those CBOs would come back to us and say, okay, we actually like at our most recent like town hall or community gathering, we did a quick presentation or we did a quick announcement about this, about the young adult expansion. Some people are now coming to us saying they want to sign up. Where can we send them to actually get help, filling out the application? So I think there's a role for organizations upstream of even the enrollment assisters who have the expertise to navigate all these complexities of the application process, but funneling people even into like getting connected to an enrollment assister or a navigator is going to be a huge role. There's a whole, I think, a world of like stakeholders and CBOs and partners that are going to need to be supported and funded to even get people to even the navigator who's going to sit down with them and say, okay, here are the documents you need. Here's how we figure out what your, what your status is. Some people are like, I have work authorization. What does that mean? That's not the same as your immigration status, but so helping them navigate all that stuff. So it's going to take a lot of different partners, and certainly the counties play a key role. Certainly enrollment assisters and navigators are absolutely essential, but I want us to also not forget, the CBOs and the grassroots partners who have reach into these communities, because as we saw with the young adult expansion and what's projected right now to be the case with the older adult expansion, the vast majority of people who's newly signed up for these programs under these expansions are just the restricted scope. Folks who had at some point had an emergency are already in the system, and we're just sort of switching them over, which is wonderful. I mean, that's great to be able to automatically switch those people over and say, you now actually have, access to a much broader scope of benefits. But there are those new enrollees who we shouldn't like forget about, and I think need to make a really concerted effort and resource that effort to reach those people who aren't in restricted scope already but are out there and might have absolutely no idea that they qualify for this and have all these different barriers to actually getting them in the door and successfully enrolling. And then the last piece, my colleagues have all talked about other legislation that they're working on and issues that they're thinking about that are so related to this. For us, again, like I said at the top, CIPC is thinking about these communities and the complexities of what they're navigating. And for a lot of these people, it's not just access to healthcare, but it's so many other things that they're excluded from. So at CIPC, we are like packaging all of the different immigrant inclusion issues that we're working on, and we've called it the immigrant equity budget, and that's what we're going to be pushing for this year. So these same communities are also excluded from CalFresh or SNAP, right? And so we're working on legislation with our partners at Nourish California to do the same thing that we've done in Medi-Cal. If it can be done there, why not with all these other programs, and make sure that these same people have can put food on the table. To Dr. Arambula's point at the top of the call, so much of the nation's, fruit and vegetables and nuts, and so much of the nation's food is grown and harvested right here in California by undocumented farm workers, and they're struggling to put food on the table. And so something as basic as food assistance and nutrition for these households is absolutely critical, and that's something we're working on through our Food for All campaign. And then another one that we're working on is the Safety Net for All campaign, which is, again, these same communities, especially under the pandemic, might have lost employment or lost hours, really struggling because the wages that they were bringing home are no longer there. And unlike everybody else who could go and apply for unemployment and have some kind of safety net to fall back on, these communities, once again, completely excluded. And so the disparity is it's gaping. And so we're working on the Safety Net for All campaign. That bill would create a pilot program. So sort of testing out the model of a wage replacement program for workers who are excluded from UI. And, if that program is successful, we'd love to see it become something permanent. Other states have done that. And so on that one, actually, California isn't going to be the first in the nation, but no shame in, following suit and doing something for our communities that's, long overdue. So I'll share a link to the immigrant equity budget, sort of that package and the different bills that I talked about. And I'll stop there because I know we've got a lot more to discuss. And thank you again to ITUP for having me.
Thank you. Hopefully people can't hear this. They just started drilling in the on the floor above me. So I'm just going to keep talking. Thank you so much, Sarah. And thank you to all the panelists. Fantastic information, wide ranging, really important points. I am going to start with, I know we don't have a ton of time left. I'm going to start with maybe asking each of you if you needed to, name just, one or two or three, but not 10, Anthony, of the most important things that the state and the counties could do to make sure that the expansion is implemented in an effective way, particularly thinking about the outreach and enrollment piece. What would you highlight? And the floor is open, so anybody can jump in and answer. I encourage everybody to weigh in. Oh, and if nobody answers, I'll have to call on someone.
Well, I'm happy. I can just start off with one thing, which is I think we really need to utilize a great variety of strategies and channels to conduct outreach. We need to make sure that we're thinking about outreach that's culturally and linguistically responsive, using different messaging to reach different communities that may have different concerns or different needs, and that we're really thinking about a variety of messengers. So some people will be reached well through sort of mass media, and some people will respond better to a personal touch from a community-based organization. So I think having a really holistic outreach strategy is going to be critical.
And I know that many organizations have prevailed upon DHCS to rely on community partners to review notices, to make sure that they are actually understandable and usable, and to do outreach and inreach to different communities. I really, and Kathy mentioned that some counties are out there doing the outreach, but it's very inconsistent. A number of Pacific Islander groups are working with DHCS now on the expansion to the COFA states. And we're asking, you don't have to pay us, although paying the groups I think is an essential part of this, but can we imbue your training to the counties with cultural sensitivity training? Can you list us on your website as resources, especially because there's no language support provided to these citizens? And so far, the resistance is very high for DHCS. But I think if we can continue that pressure, it trickles down to the rest of the counties to say we can rely on our community partners to A, advise us on the best way to do outreach, and B, to work with them to do that outreach and to use some of that funding to make the work of the community organization sustainable.
Add, just to build off what Corey and Karen said about like the inconsistent, messaging among counties and the state's reliance on community organizations is really also around public charge. I think we've all heard that, people want to see public charge concerns addressed directly by the department on notices, on the FAQs, and that has been an ask for many, many years and with other expansions, but it is not addressed directly by DHCS or by the counties. So this is something that I think would be number one ask from our organization would be to bring this up, because questions come up in so many contexts on public charge and from the individuals who aren't even subject to public charge. But because there is, just so much inconsistency or changes in policy, it is something that can really be dispelled with, an official documentation will go a long way with doing that.
Yeah, I mean, I would echo my colleagues in a couple of things that I would categorize in a couple of ways. One is, as much as we can do automatic, great. Like, so that lift and shift strategy that Kathy was talking about earlier, we have folks in restricted scope Medi-Cal, we know who they are. The more that we can do that automatically, seamlessly, administratively, simply, great. I think also what Kieran and others talked about with regard to the need for outreach and outreach specifically to these communities, you know, and the strategy for the 50+ population is going to be different than the young adult population, but overlapping Venn diagram, but will need to be distinct, and frankly, some of that takes money, and so supporting the budget requests that CPN and others will have to invest in that kind of outreach, as well as doing it, you know, through the various mechanisms, the county workers, the community groups, the full infrastructure we have. And then I do want to just say that at the end of the day, it's, I think, what we're talking about broadly in this conversation, which is the culture of coverage, that just having a culture, that having a system where throughout our system, wherever people may find themselves falling off coverage or whatever, that we find pathways to get them back into coverage as automatically or administratively simply as possible. I think you know, there is the theory of the targeted universalism, that we need both broad reforms that impact everybody, and we need the targeted outreach and to deal with specific issues like public charge, like these other issues, and we need to do both, right? We need to do things on scale, and we need to have to deal with specific communities and meet them where they at with their specific concerns and the specific strategies that are unique to them. That there's no place in the country that's more important than California.
Absolutely. Sarah, I want to give you the opportunity to weigh in if you want briefly, and then I think we're actually going to have to wrap up in a minute. How did that happen?
I know there's so much to say. I mean, it's what people have already said. I think resourcing these grassroots organizations that have reach, again, anytime there's, you know, an expansion or a new policy, like Anthony said, targeting the best way to reach that community with its unique needs and barriers is important. This is a community who, by and large, has not interfaced with the healthcare system, you know, ever in many cases, other than maybe community clinics and safety net providers. But for so many people, it's not even that. And so it's going to take a really concerted effort and really resourcing. The groups that have reached into these communities, again, are not always the traditional, they're not always the groups that are, you know, would consider themselves part of like the healthcare system. And so I think there's a big bridge to be connected. And I think thinking about the most grassroots and upstream stakeholders who are connected to these communities, you know, who have family members themselves who are undocumented, who really know and understand and are trusted by the community, I think are the ones that, you know, need to be resourced, because they're pretty strapped. They're trying to deal with a lot. And so, especially post-COVID, with all the things that we just talked about. So it won't be possible without some kind of support and resourcing.
Fantastic. Thank you. It would be impossible for me to, I'm sure somebody could do it, but I can't pull all of this together in the remaining, 90 seconds or whatever I have left. But I will say that just at the highest level, one of the themes that I heard each of you talk about that came through so clearly is just the need to really understand and meet the communities of the newly eligible population, the newly eligible Californians, where they are, right? So that means, Kieran said, lean into the diversity, understand that these are, this is not a monolithic community, and different folks have very different needs. Corey and Anthony and Tiffany all talked about, don't forget about also affordability and the affordability barriers that people have, and addressing those. That is sort of at the highest level, is really like, let's try to craft a system that's centered around the people, right? And let's try to move in that direction. So thank you, everybody. I'm going to turn it back over to Katie, fearless leader, and thanks again for a terrific panel.
Amy, thank you so much for being such an incredible and capable moderator. And a huge thank you to everyone on the panel for your leadership, your long work in this, and your continued detailed work. I really appreciate the discussion of the nuanced community needs, and that's exactly what we're going to talk about next. So it's my pleasure to turn this over to Madeline Sabatoni, who's a program officer with the Sierra Health Foundation. She's going to talk through some of their lessons learned in that they did in the recent expansion to young adults, as well as moderate this next panel. It's just our pleasure to bring to you some of those and put some faces and names to those folks working in communities, doing outreach and enrollment, and really thinking about the specific needs of these very vulnerable populations. So Madeline, thank you so much for joining us today, and I'll hand it over to you. Thank you.
Thank you. Thank you so much for having me. It's an honor to be here with this wonderful panel. And I won't take up too much of our time this morning so we can get straight to our panelists. But we're really going to now transition from that policy lens to that local perspective of coverage expansion, which is just so essential to access, as I think we heard from the last speakers. And there's many lessons that we can learn from these folks who are working on the ground. And we hope to dive deeper into the value of CBO and government partnerships, the infrastructure that's needed, and more. I know more recently at the Center at Sierra Health Foundation, DHCS asked us to go into 4 regions where local infrastructure was really limited to help with that outreach and facilitate enrollment and build that capacity of our CBO partners. And we learned a lot about that, and we actually wrote a paper about that. So I'll put that in the link in the chat, and you can all check that out. So I'm looking forward to hearing from our panelists, and we'll just jump right in. And if you have questions, feel free to put them into the chat. So panelists, if you want to just take 5 minutes to get going and introduce yourself and your organizations and the communities you serve, and the role that your organization will play in rolling out the upcoming and proposed Medi-Cal coverage expansion efforts. So we will start with No Paramo, who is the Director and Legislative Advocate for the California Rural Legal Assistance Foundation.
Good morning, everybody. Thank you, Madeline, for that introduction. It's a privilege to be here with ITUP and all of you in this very important program. And I'm Noé Paramo. I'm with California Rural Legal Assistance Foundation. We're a 40-year-old legal aid serving organization. We're a nonprofit, and we focus on rural immigrant farm worker communities. And we have a team that's dedicated on health and immigration and the intersection of that work. And my comments, just to start us off, is that the investment in expanding Medi-Cal eligibility to the older undocumented immigrants is truly historic and extraordinary. I've been working over 25 years in this area, and from the time we did Hurting in the Heartland with Joel Derringer, and an expert in this area, I had the privilege to work on that, till now that we're seeing in incremental steps this opportunity to expand coverage to undocumented immigrant farm workers, particularly in the Central Valley and our other regions, the rural Inland Empire and the coast. And it's very important because all our farm workers, our adult farm workers, have worked for years putting food on California's table while lacking healthcare when sick, and more so during the pandemic as essential workers. And we're going to face those issues with our communities as we see what are the long haul effects from the pandemic. The expansion represents both a challenge and opportunities, and we've heard about the importance of working with community-based organizations, and I echo that and affirm that. It's going to be vital to work with our community-based organizations, the promotoras networks, advocates, and other stakeholders serving immigrants and farm workers to provide that much needed education and outreach. In addition to the expansion, the information about eligibility, the income and asset requirements, and as well as the public charge information, immigration information will be vital. All that is got to be addressed, and at the local level, either through a ground or a air game, right, using our radio stations, such as in Fresno with Radio Bilingüe. And then those grassroots groups was working with a group in Kern called Health for Kern, and looking at how to do the Medi-Cal outreach in Kern County, as well as tying in the Cal Lane, because both of those are going to be necessary to educate and inform our communities. And what's really critical here is the groups are working on these enrollment and expansion of the programs on their own without a lot of resources. We need to get them the help. So we need our state and local leaders to dedicate resources to these trusted and credible community-based organizations to ensure a successful implementation of the expansion. And, you know, as we dig deep into what's that mean, you know, our farm worker community, a third, like 30 to 40%, are indigenous farm workers that have a language other than Spanish, and that's Mixteco, Triqui, Zapoteco. And so we need to work with those groups to really work with the communities, because that's who they're trusted. I'll hit on an issue that's very important as we look at how we're going to expand this coverage, and also a solution that we're looking at. So an issue that we need to really understand is just because the coverage is available does not mean that we're going to lead to enrollment or increased utilization of services, especially for our farm workers, right? So understanding migratory patterns, wary of the government to trust, language that I referred to, all these aspects are important to look at. And at Sierra Leone Foundation, working with UC Merced and ITUP, we're looking to address these areas and come up with policy levels, policy issues to address these levels as we roll out the 50 and over, but also the 26 to 49, where there's going to be this larger amount of farm workers, because we need to close the gap and expand it. We looked at farm workers that go in and out of coverage because of the income. And so those are some of the things we need to do. So the outreach and education is key, lessons learned from that, and then apply policies that we learned from the work we're going to need going forward. Thank you for that opportunity, and happy to continue answering any questions as we move along.
Thank you so much for that. I think that just because coverage is available doesn't mean it leads to enrollment. I think that was a huge takeaway. Annie Chung will go next. She's the President and Chief Executive Officer of Self-Help for the Elderly. Annie.
Thank you, Madeline. I echo everything that Nose just said, and it's really an honor and a privilege to be invited to this panel. So thank you, ITUP team. I'm Annie with Self-Help for the Elderly. We're like a 56-year-old, really community-based organization, first started in San Francisco and then expanded to 4 other Bay Area counties. And we serve roughly 40,000 elderly in a year, but we have a very comprehensive range of services. And most of our seniors, I would say 80–90% of our seniors that come to receive self-help services are the monolingual seniors of a very limited English speaking capacity, a very low income, and also immigrant seniors. So that's really have been our target population for the past 56 years. So our role that we foresee that we will be playing, well, first of all, I'm very excited about the expansion of the Medi-Cal program to people over 50 years old, because by helping them, to take advantage of the healthcare that they would receive free of charge, that frees up very little money on fixed income. Some of these older adults are living on very, very low income, and that would help to make their lives, the quality of life really a little better. And that has been the mission and goal of self-help ever since we established in the community. But it's exciting for the Medi-Cal expansion to people over 50 is because we are already seeing, and the 2 statistics that I'll share right now with you is for the homeless population. You might have read or heard that 50% of the current homeless population in California are over 50 years old. And the second very scary statistic is the 65 plus age cohort is the fastest growing population among the unhoused. So they're very at risk, and the older adults, need to be provided really extra care from the community. And the Medi-Cal expansion to this population is really welcomed and very much needed. So we look at self-help to play a, of course, very active role, and being a community-based organization that been addressing the needs of this population that this expansion will be targeting, right? The 250,000 plus potential Medi-Cal recipients. Many of them really may not know, that they are now becoming eligible in May, and many of them don't know where to get the assistance to help them gather up all the papers and fill out the very complicated application form. So this is where CBOs like ours and others, like NOES and others come in, because we're already the trusted partner, right? For many, many years, our clients come to us for congregate meals, home delivered meals, COVID response. During the COVID pandemic, a lot of us have been really nonstop in pivoting in order to meet the emerging needs that we see in our population. For example, instead of serving congregate meals, we switched over to home delivered meals. Instead of providing a lot of classes on healthcare and special interest, special hobby classes, we pivoted to the internet by teaching our even least technologically endowed seniors how to use Zoom and other simple platforms so that they could join some of these healthcare lectures or talks or gardening or meditation, Tai Chi or yoga, something to help them to overcome the pandemic. So I see that the role that we'll be playing is quite a bit. We could, for example, work with ethnic media to outreach, to our limited English LEP population, that the expansion included now people over 50. And if they're eligible, they should seek out, a community partner who the local HSAs hopefully will be working on to make the enrollment process easier. We should bring services to the people where they are, not make the people go to limited government agencies to fill out the application, particularly during times of pandemic. I hope that the Medi-Cal officers that are in charge will really work with the CBOs early on to tell us, the whole criteria, enrollment process, let the CBOs ask all the questions, provide input to make this application and enrollment process easier and more culturally competent. I do think that in the Bay Area, there are going to be tens and thousands of older adults that will be looking, for this opportunity to enroll, but just didn't know where or didn't know how. So we have to work with the trusted partners to make sure that these services are available to them. We could do focus groups to pinpoint, where the gaps are. We could work on enrollment and come back to provide input to, again, the HSA or the Medi-Cal office as to what is holding back the potential population that could get the Medi-Cal but not able to get it because of maybe public charge, immigration, or other kind of questions. For example, when we did the CalFresh enrollment for seniors with SSI last year, when the law changed to allow SSI seniors over 65 to also get the CalFresh, we were very successful, for about 6 months. Then everything kind of slowed down and stopped. But why? Then we found out that there weren't a lot of businesses in our community that accepted benefits cards. So when we provide this type of feedback back to the HSA, and then they went out and recruited more businesses to accept the EBCs, then the enrollment picked up again. So utilize the CBOs to work with the HSAs or with the Medi-Cal office so that we could do better outreach, more targeted outreach, be a place where the over 50 older adults could come to get assistance, or get information, help them gather up all the paperwork, and maybe authorize us, to also do some of the enrollment online. So those are probably some of the roles that CBOs like us could play. So I'll stop here and maybe answer some questions later. So thank you, Madeline.
Thank you. And the last panel talked about meeting people where they're at, and you're showing how CBOs are essential to doing that, because you have that flexibility to pivot and meet people where they're at and reach them. Next, we'll go to Dr. Elaine Batchelor. She's the Chief Executive Officer for the Martin Luther King Jr. Community Hospital. Dr. Batchelor.
Good morning, everyone. Thank you for inviting me to join this conversation. So I'm the CEO of MLK Community Healthcare and Hospital located in South Los Angeles. We are a private safety net hospital and health system that serves over 1 million residents of South LA. About 60% of our residents are Latino, and about our patients, and about 40% are African American. They are almost all low income. Over 80% of them are insured through Medicaid. While I applaud our state and the progress we're making in our state toward expanding coverage and toward universal coverage, I'm a strong believer in universal health coverage, and also applaud them for addressing health disparities and social determinants of health through CalAIM. I am very concerned about the lack of access to high quality health care in our Medicaid program. And I want to caution all of us that coverage does not equal access, nor does it equal quality. While having an insurance card is much, much better than not having an insurance card, because at least it gives you access to an emergency department, it does not guarantee that you will have access to either primary care or specialty care. South LA is a place where decades of underinvestment has burdened a community with an epidemic of chronic illness and some of the worst health disparities in the state. These disparities were reflected in the disproportionate impact that COVID had on our community. CNN actually called our hospital the epicenter of the California COVID epicenter. We had more COVID patients than large tertiary medical centers. Central to the health disparities in our community is a profound lack of access to health services. Our community has a deficit of 1,300 physicians. Our hospital emergency department has become the place residents seek care because they cannot obtain care timely in the community. Our emergency department is filling significant gaps in both primary and specialty care. As a result, we provide 100,000 emergency department visits each year, one of the busiest EDs in the state, in a small community hospital, and over 2 times what was envisioned when our hospital opened in 2015. I'd like to share a few examples of patients we care for in our emergency department. A patient with abdominal pain recently presented to our emergency department because an appointment with her primary care physician was several weeks away. Our doctor's workup found a large abdominal tumor that needed immediate oncologic care. Patients with diabetes and hypertension, unable to see their primary care physicians, present to our emergency department every single day. Our emergency department is the site of routine care for women with pregnancy-related complications, routinely providing follow-up visits and monitoring because they cannot access an obstetrician in the community. Lack of access to care has turned our emergency department into a de facto medical home for thousands in our community. The root cause of these access issues is inadequately low payments to providers. So while we applaud the expanded coverage, we need to address the low provider payment rates. Medicaid pays pennies on the dollar to providers compared to Medicare and commercial insurance. As a result, low-income communities dependent on Medicaid, lack doctors, healthcare services, and quality. And because so many of our communities of color are dependent on Medicaid, we've essentially created a separate and unequal health system. And that's something that I think we can do better, and I would like to see us change. Thank you.
Thank you, Dr. Batchelor. And thank you for giving some kind of personal stories to the issues as well. Jan Spenceley is the Executive Director of San Diegans for Healthcare Coverage. Jan?
I had to unmute there. Hi, I'm Jan Spenceley, as you heard, San Diegans for Healthcare Coverage. Who we are is a consumer advocacy organization. That's how we began. That's where our roots were. In fact, before we even were formed, Dr. Ross had a group at the county trying to look at all of the eligibility and access issues. So we do consumer advocacy, mostly in the policy arena. I love what Corey said, systemic policy. We're constantly after that. And also we provide consumer advocacy on an individual basis. And we provide assistance, direct assistance. We convene, which I consider to be one of our most important activities, and that's collaborating. We collaborate with community clinics, with the community clinics in San Diego, which we are rich in. We collaborate with the hospital systems. We collaborate with legal aid and their partners. We collaborate with the County of San Diego and try to work on barriers in the eligibility arena. But I'm a believer in access to care. Coverage is a means to access to care, which is why we have that in our name. So we also address access issues on a regular basis. I don't want to go through it. First, let me just say something. I'm really happy to live in California. I feel blessed because I think we've done everything we can. And we've pushed the envelope with the ACA, the Affordable Care Act, and it makes me happy. I always want to do more, right? I want performance improvement at every level. And so I believe that several people said coverage is not access to care. And so we're getting really good at the coverage, but not the access to care. As it relates to the expansion of coverage, I'm just going to report our experience. San Diego is large, as big as Connecticut, pretty much, same as population, but our makeup is quite different than Connecticut. We are bordered on the south by Mexico, and it is the busiest land border in the United States. That's relevant. I think people need to understand that's relevant in our community because ICE is there. And there are different factions within immigration and naturalization and USCIS and all of those people, but it doesn't matter. These people engender fear. And during the last administration, things got very ugly. You saw it on the news, you saw it everywhere. That hasn't left anybody's memory in this community. So I'm really happy that I was listening to Karen and Sarah both say the same thing. This is not just about public charge. This is a fear of leaving your home. This is a fear of watching your child's soccer game. And so the idea that we're talking about, hey, come get covered, is not top of mind. So when I look at the expansions, what we're seeing are users. They're people that need healthcare. Our children have stayed flat. Our enrollment of children has remained flat. It's not because we don't have wonderful clinics. It's not because we have a lot of clinics. We have a lot of CBOs. We have a lot of immigration organizations. But the fact is they can't talk them into it. They can still get their well child stuff without enrolling in Medi-Cal. So I think this is extremely important. I really enjoyed what I heard today. I would love to talk more with some of the immigration folks about the upstream. I'm going to add to that, and I'm just going to say, let's talk about employers. Either these families are these individuals. They're fearful for themselves, or they're fearful for a family member, right? Or they're fearful for where they are. They're farm workers. Let's talk about getting to the employers and educating where they live and where they work, because somebody in that family works, right? Most of these people have jobs somewhere. Whether it's, and We don't have to talk about whether they legally have jobs. We just have to talk about education. So that's one of my sort of key points about this is we just went through a whole thing and they're saying the county needs to make a statement. I said, nobody cares about the county. Nobody cares about the county because they aren't deporting people. They aren't removing them. They care about the federal government. And I remember in the old days, and I also just, I remember in the old days when we had that letter. Remember, I don't know if everybody remembered the letter. We had it everywhere, in every clinic, in every place, saying that Medi-Cal is not a public charge, right? And we can't get that anymore. I just want everybody to know we can't get that because everybody's fearful about what they say. The notarias and the immigration attorneys are telling people, if you don't have to use benefits, if you don't absolutely have to, don't sign up. So I think it's important that we all talk about how we get that message out there without equivocation and make it clear, but people are fearful to do that because everybody's circumstances are different. But I want to also say it's not just eligibility, it's access to care. And that's for everybody. I just want to point that out. Medi-Cal is the worst, but my Medi clients have horrible times. I'm constantly interfering and interceding for them. Commercial clients, individuals that are insured, they have problems. I mean, people who work, I'm not going to say names of organizations and places where you'd think they had great benefits. But we don't know what those access problems are because we don't have a statewide database. We don't have a health information exchange. There are like a whole list of things. Listen to me, Anthony. We need to update our Knox Key because it's woefully out of date. Can't enforce it. Just horrible, egregious things, and they get passed. We need to eliminate the silos that right now individuals have to navigate across agencies, across services, across providers. And those are our own government creates those. So I want us to think about when somebody needs to use adult protective services or aging and independent services or MSSP or whatever, and they need behavioral health and they need health and they need housing and they need in-home support, all of those things, they got to go to a different silo and go through the same crap over and over, excuse my language, same stuff. Why? State can deal with that. We don't have to do huge things to the system. Right now, CalAIM is a patchwork because it's only one population, one thing, and it doesn't look across the system for everyone. So I believe a statewide HIE is a good idea. I think the infrastructure should come before the major change and then eliminate those silos. And let's face it, doctor, we need more doctors. We need more doctors. I mean, it's clear to me that everybody's having access issues. Doctors are leaving California. I just heard of 2 more this morning. It's just, they're leaving, they're going because of Medi-Cal, because of the complications, because it's just too much, right, for them. And they're going to Idaho or they're going to Montana. They're just getting out. And by the way, we don't know that we need more doctors because we measure nothing. So I'm just going to keep going back to, if you don't measure it, you don't know what the hell's going on. And I think we've had an okie doke from the local to the state level of not doing that. So if you don't do it, then you don't have to address it, right? So this gets back to GME, gets back to federal, state, whatever, and how it's structured today. And so we need to fix it. GME, for those of you who don't know, is General Medical Education Funding. I don't even know if we still have Song Brown, but we're not doing assessments of how many doctors we have and how access is being provided. We're counting the same doctor 20 times for all these plans. So we have no idea, right? So those are just a few of my little thoughts on the access to care issue because everybody took my other things.
Well, thank you, Jan. And I feel like maybe ITUP could do a whole other session on access and quality to care. So perhaps something to think about. You kind of discussed a little of this, and I'd love to hear from the others about it. But what do you need? What do you all feel like you need from state and county governments to support you in these efforts? Jan kind of named a few things, but
You can join me. You can join my bandwagon.
If I may, this is Noé. I'm going to take a pathway from what the state's already invested in, and they need to really uplift what they've done. And so during the pandemic, CDPH and the labor agencies had the health and worker outreach program. And those are models that are there, they're funded, but they're not going to be permanent. But so you can take models that have been applied, and they brought in these grassroots community-based organizations to work on the ground with, and they're trusted. They've been getting the training, know about misinformation, and you could really apply this to the expanded Medi-Cal, but there needs the funding. The groups have the resources that are very limited, and Annie talked about where you need to go. And for our farm workers, when you talk about a vast geographic area, the language access issues, the transportation issues, the immigration risks, going to school, families separating. So all that trust, you've got to go back to the community organizations and work with them and fund them. So the state needs to step up here. We know they can do it. Now will they do it? The other part is at the local level. And you're going to see a very fragmented system from county to county. Some counties are already up and going. LA County, for example. In the Central Valley, you're going to have counties that the boards are not going to step up. You're going to have to work with the agencies at that level, and the agencies and the community-based organizations work together to try to collaborate and address it in that way, particularly with farm workers. So there's still more work to be done. As I said in my comments, the opportunity is there, but challenge is there, but we know that there are also solutions that can be done.
Thank you, Noe. I'm curious also, as you kind of talk about, utilizing CBOs, what is that basic infrastructure that CBOs need to do this successfully? We've heard things around challenges around data. We've heard things around, technology, training. What do you all think is essential for CBOs to have to be successful in doing this?
I could start. So for CBOs like ourselves, which has a very targeted population, so when the government unit need to reach us because they cannot reach the monolingual low-income Asian seniors that say live in San Francisco, then they come to us. But by then, the program is approaching its deadline. I'm using let's say the renters assistance program, right? So when they look at their database and say, after a year, the Asian community is not quite reached the number because we have a very large Asian population in San Francisco, then they come out to start looking for AAPI or different CBOs to help them to get the word out, as well as filling out the rental assistance forms, right? But by then, you're really approaching the deadline. It doesn't give us much time, right, to be successful before the moratorium of eviction started. So I use that as an example that when this last minute, then the agencies will come up with some funding and say, we will provide you X dollars if you enroll X number of people. Why don't they do it earlier so that there's a systematic way of outreaching, talking, representing and enrolling? But if you leave LEP communities to the last of your priority, then the uptick won't be as successful if you include us in the beginning. So second need, I think is really real, is technology, Madeline. I use the census as an example. Like when a lot of the minority community refused to complete the census forms, right? Then the Census Bureau got panicked and then start to work with local government to come up with some, again, funding so that we could fund community partners to help them stand in the street corners or go door to door canvassing in order to ask people to fill out or complete their census form after the citizenship question was taken out by the was taken out already, right? So we then say we're willing to do it, but we need laptops or iPads, right, to help us do the work. But the government sometimes work too slow. So in order for us to do the work that we are willing to do, we then have to go seek out a philanthropist to pay, for 60 iPads that we could spread out so other community partners could, do the filling out of the census form right standing at the street corner. So technology needs training, definitely. Don't pick a community partner and just throw them out, and then let them sink or succeed. But really act as partners so that when we have questions, some flexibility, because we do a lot of work on weekends, right, where we could reach people, particularly the over 50 might be still working. So reaching them work days 9 to 5-ish would not be good. So I need partners from HSA and Medicare office to also be flexible, to be available on the weekend when we need to access them, right, for information, so that we're not delaying and then letting people wait till comes Monday or Tuesday. So it's that kind of real partnership, so that we're accessible. We really are the bridge from the resource, people who provide the resource, to people who need the resource. And to be a good bridge, we need both sides. Yeah. So those would be some of the CBO needs.
And
I want to make it clear. I do believe the CBOs, they need more than just they need resources. I happen to also agree that getting resources is bureaucratic and ridiculous. There needs to be more flexibility about how we do that without breaking anybody's rules. But the other part is that I'm going to keep coming back to, well, for somebody asked a question in here and I wanted to answer it. That was one of the things I raised for. Most communities have either CBOs or clinics that will provide assistance. Somebody asked the question, where can you get it? Where can you get help for getting restricted scope now? We're almost too late, but and you can usually find a CBO, a community health center, FQHC, community health center, community center, or that county has an office, should have an office if you can't do it. You can also, if somebody helps them, they're going to do it online, most of them. So and we found in our studies that a lot of these folks they can't do that application online. It's not even in English. I mean, it's not even in their language in many cases. So that's how you would get help getting onto restricted scope, and then in the future, full scope, if you're somebody. I wanted to make sure that people knew that there are a lot of places to get help with Medi-Cal.
Thank you. I was just about to raise that question from the audience. So what types of resources are useful? What types of things are needed to support the CBO?
I can just tell you what we just learned, if that's okay. They want simple, digestible, factual, kind of straightforward information. Not with a lot of conditions, qualifications. You can't say to somebody, this doesn't count for public charge. That a lot of them say this probably won't count for me. It's like, it's making sure that they have something that is whatever the information is, eligibility, access to care, anything should be simple and digestible. And sometimes we get carried away with putting all these, required notice stuff in there, and it makes it confusing, kind of like the applications, a little hard for people to understand. And that was feedback we got. We got about 7,000 surveys back from Medi-Cal beneficiaries on what their issues were and how they would like to get information. And one of the biggest things that came back was just too much. They don't even understand it. It's just too much complicated language. And by the way, they like texts. In case you wondered, people like texts.
I will give a couple of examples of a work that we're interconnecting with. So for example, in Stanislaus County, I'm in Modesto, there's an immigration roundtable that's held periodically. Well, we bring the immigration experts and also the local agencies together, and we provide them with the information about what's going on in immigration, and then tie in the different aspects, such as when the pandemic, and now with the Medi-Cal 50 and over public charge, so that they're informed. So there's this cross communication as well. In Kern County, working with the Health for Kern Coalition, just this week, we talked with the CalAIM person at the county and what they're doing with the enhanced and community support services to connect with the community-based organizations, as well as the expanded Medi-Cal, what's going to be coming up. And so you have that communication, and you take the work that the community-based organizations have done in Kern County with the vaccinations, with food distribution sites, vaccination sites, testing sites, and connect it. And so you do the ground game at the sites where those events are happening. Then you do the air through media, through newsletters, and then the aspect of social media, using good information, not get caught in the misinformation. So we need to dispel that and cut through in a very straightforward, community-friendly manner. And Jan hit on that, and Annie's hit on it. It's community-friendly, that you got to do away with the policy wants stuff. We'll do with that at that level, but community wants to know, and the basic information, and work with the trusted groups who will convey that. So resources that address that, and then it might be in the form of stipends for the promotoras, might be in the form of salaries for expanding capacity for the community-based organizations, and maybe be the form of laptops or tablets to bridge the digital divide and take them to sites and help people right away, immediately that way. It might be use of cell phone. So all these different technologies and brochures and materials and in a toolkit that the community-based organizations, knowing their residents, will work.
A question from the audience. They're interested to hear about if the panelists or CBOs are working with their community information exchanges. So, working with community information exchanges.
And so you know that my community has one. I don't know if others do. That's scary.
I'm also going to switch us to another question. What supports do hospitals and Medi-Cal providers need from the state and county to meaningfully connect with and provide services to the larger Medi-Cal population? Dr. Batchelor,
I think you heard what my view is. You know, the hospital has become the dumping ground for people who can't access services in the community. So what we would like to see is adequate payment for community-based services so patients can get the prevention and disease management they need in the community and not end up in the hospital needing heroic and end-of-life care. Diabetic amputations are the #1 surgical procedure we do at our hospital. Just think about that for a minute. This is a completely manageable and preventable complication with appropriate management in the community. So, you know, what we're advocating for is adequate resources and investment, particularly in low-income communities that are highly dependent on Medi-Cal, so that our residents can access care in the community and they won't end up in the hospital needing to have an amputation or a dialysis graft inserted because they have end-stage kidney disease. And that is the reality today.
kind of building on that, so from your perspective, Dr. Batchelor, from a hospital that serves a lot of uninsured and Medi-Cal patients. What do you need to make coverage outreach meaningful to move the care you provide away from primary and follow-up care?
I'm not sure I understood your question, but I will say in terms of coverage, we follow up on every single person who comes into our hospital who is uninsured to make sure that they know about the availability of coverage and that they are taking the steps to get covered. So I'm not sure that I'm answering your question exactly. Maybe can you repeat it if I didn't quite get it?
Sure. I was asking just, what do you need to make coverage outreach meaningful so that you're moving away from primary and follow-up care?
Yeah, I guess I don't understand that. People who have coverage still don't have access to primary care. That's the point I'm making, is that Medicaid coverage does not equate access or access to primary or specialty care. So we do everything we can to ensure that our patients are covered, but that does not translate into access.
I'm going to, as we only have a couple minutes left, I wanted to ask one last question of just what all for you all is the action item that you would have, your last thoughts for local entities for the state. What's your call to action?
At 2 points. One is invest in community-based organizations. They're the trusted, incredible groups on the ground in this process of enrollment and 50 and over. And as you go forward into the 26 to 49, we hopefully it stays in the budget. And now you're going to see that expansion across. We know it's incremental. It's not universal. And there's going to be gaps. So that leads to number 2. For farm workers, looking at the policy options and the models that we close those gaps. So make sure farm workers are inclusive, they get addressed for these care. And then, Jan's talking about, and Dr. Vashler about, one thing is to have access, the other is to get the care and then the coverage, right, that follows. So, so those 2 points, the outreach and education key. Then the second is we need more policy recommendations, the implementation of those recommendations, particularly for our community farm workers, so that they can avoid these health risks and then increase utilization.
I'll go next, and I'll just say that I'm going to say that the biggest issue for me on access is if you don't measure it, you don't know it. And I want a statewide infrastructure. The state has the power. The state holds the licenses of every provider in this state, and using either using or interfacing with a statewide HIE will begin to tell us how great a need we have. And until we have a sense of how great that need is and how that diminished, as the doctor said, she didn't have providers in her area. Well, somebody's got to measure that. And you got to see who's the throughput. So I'm going to just say that would be my biggest thing. And it would go straight up to the state and say, you have the power now, just get it done. And I'm probably going to get beat up by all my people here locally, but life's a bitch. Sorry.
I'll go next. So my call to action is also, like Noe said again, like reach out to your community partners now. Don't wait till May, when the program is up and running, and then you say, we haven't done so well for this group and that group. So do your strategy thinking, and the community partners are already probably doing some of the work, for the government agencies. And now it's also time to look at your budget. We keep hearing that both counties, cities, and the state have surplus budget this year. So if there's any surplus budget, set aside additional resources so you could fund some community partners to do the work with you. We don't need a lot of money, but we need additional resources, like paying for some extra time that staff work on the weekends, or buying, a few laptops to bring around, hotspots, and also give us some access to the eligibility workers so that if we have questions, we have a direct link instead of waiting 2 hours for someone to call us back. So those would be my call to action. If we are to do a good job, you're going to need a lot of the CBO partners to do it with you. Medicare, yeah.
So I guess I'm last. I would encourage all of the advocates who care about our underserved communities to strongly advocate for adequate investment in community-based care. That's my siren song.
Well, thank you to all of you. I think those are all such important takeaways. So I hope everyone was listening with open ears. Thank you all for joining us on this panel. I do want to just mention, because it goes along so nicely with the conversation that we had today, the paper I mentioned at the top of the session really does also include an outreach and enrollment essentials checklist that people might find very helpful as they embark on this work. So with that, Emily, I will turn it back over to you. I know we're at time.
Great. Thank you so much, Madeline. In closing, I just want to express ITUP's gratitude to all of today's incredible speakers for their time and expertise, and to say thank you to our attendees for tuning in. If you have any questions about today's forum, you can reach us at info@itup.org, info@itup.org. Thank you all so much and have a great rest of your day.